Let's kick off this chapter by defining the term. So Dr. Pete, what is rhythm control?
Good question. Rhythm control means keeping a patient in normal sinus rhythm. So if a patient is having intermittent or what we call paroxysmal atrial fib, where the episodes will stop on their own, we don't have to do anything to restore their normal rhythm, but rather we give them therapy to prevent further episodes of their atrial fib until they'll maintain sinus rhythm. However, if a patient's in what we've defined as persistent atrial fibrillation, then they would first need to be put back into normal rhythm. For this, we use cardioversion. It's a process that restores normal rhythm and can be done using drugs in some patients, but more commonly, we use electrical energy through patches that we put on the chest wall, and they will restore the patient to normal rhythm.
A lot of us in the movies or on TV have seen emergency personnel rushing to a scene to shock an unconscious patient back to life. Is that what you mean?
Yeah, I'm well aware of those kind of scenes. They're very dramatic. They depict patients who have actually a life-threatening rhythm. They're unconscious, and they're basically going to die unless they're put back into normal rhythm. They come and they shock their hearts back, and it's a big dramatic scene. We use the same type of electrical energy, but it's a much more calmer procedure. It's set up in advance. The patient's typically stable, and the procedure is done in a more organized fashion. There's no drama involved in our procedures. And as you can see from this illustration, specialized patches are placed on the chest wall through which we will put electrical energy to deliver to the heart. And as you can see from this figure, the electrical energy will restore normal rhythm. The patient is fully under anesthesia, so they don't feel any discomfort, and this is how we restore normal rhythm.
Could you show us what that looks like?
Sure. This is an animation of looking at a heart in atrial fibrillation and then having it go back to normal rhythm. So as you can see, the original, in the initial one, the patient's top chamber is beating really fast. The rhythm is chaotic, as we've talked about before. It's an irregular rhythm. A shock is given to the heart, and now you can see the same heart now is back to its normal rhythmic state. Top chamber's in sinus rhythm, bottom chamber gets regular impulses, and we're back to the normal sinus rhythm.
Are there any preparations needed in those scenarios?
That's a very important question. In most patients, but not all, they do have to be anticoagulated for a certain period of time before the scheduled cardioversion. This minimizes any chance that a stroke will occur after restore sinus rhythm to the patient. Now, this can be done by simply waiting a number of weeks until the blood thinners have a chance to dissolve any potential clots in the heart, or it can be shortened by a process that uses a method to detect if any clots are in the heart before the cardioversion is performed.
Could you describe that shortened approach?
Sure, Lindsay. The standard approach to evaluate for clots in the hearts is called a TEE, or a transesophageal cardioversion. The esophagus lies directly behind the heart, and this is shown in the figure that you can see here. When the patient is adequately anesthetized, a small tube is placed down their throat into the esophagus, and it's positioned behind the heart. It has an ultrasound on the end of it that can evaluate very, very carefully the left atrium and detect if any clots are present there. In this figure, you can see that a clot is present, and that clot is called a thrombus. And in such an instance, the patient would not undergo cardioversion, and it would be done at another time after we've had a time to dissolve the clot. If no clot is present, then the cardioversion will be undertaken at that point. Using the TEE approach can shorten the time it takes to restore sinus rhythm by several weeks. The method of waiting several weeks with anticoagulants and TEE guided approach are really both safe if they're done appropriately, and a discussion between the doctor and patient should be undertaken to determine what's best for that patient. Recently, we've gone to using what's called a CT scan to detect left atrial clots as an alternative strategy to the TEE. Last of all, in some patients, it's best to really start a drug before going to cardioversion, because this may minimize the chance that after the cardioversion, they really go back into atrial fib, and this should be discussed in detail with their physician.
Okay, Dr. Pete, how do you keep a patient in normal rhythm? Because that's the goal, right?
The goal is to keep in normal rhythm, exactly, Lindsay. To keep patients in normal rhythm, we have to either use antiarrhythmic drugs or a catheter ablation approach. Let's discuss the drugs first. As you can see from this list, quite a variety of drugs are available for use. The best drug for you needs to be discussed with your physician. Some drugs are not safe for some patients, for example, those who have heart failure or coronary artery disease. And as this figure shows, that in different situations, some drugs are very safe and other drugs are problematic. An example, amiodarone. Amiodarone is the most effective drug we have, but the problem is it has a lot of side effects that patients would like to avoid. And that's why when you look at this list of how we position drugs, you'll see it's not top-line drug unless a patient really has very few other choices. And I think it's important for patients to ask their doctor about the side effects of drugs.
How do the success rates compare when we're looking at ablation versus drugs?
This is actually a very important question, Lindsay, and multiple trials in the last several years have addressed this issue. Antiarrhythmic drugs can be quite useful to maintain normal rhythm in many patients, but most studies show the technique of catheter ablation is more successful to obtain this goal. These are data from a major recent study that show the success for maintaining normal rhythm in patients given drugs versus catheter ablation. While both methods can work in many patients, when they're compared against each other, as depicted in the upper red line, catheter ablation is superior to drugs that are shown in the blue line on the bottom.
Let's go back to catheter ablation. How exactly does that work?
So, in most patients, atrial fibrillation begins in the pulmonary veins in the left side of the top chamber, the left atrium. These veins have a muscle coating around them that is typically the source of AFib. This muscle coating is shown in this figure, and you can see it on the outside of the veins. As you can see from this example, that is done in the laboratory when we have an actual catheter in one of those veins. On the right side of this, you can see rapid beating coming out from that pulmonary vein. That's coming from the muscle that coats the vein, and that's what gets into the heart and creates atrial fibrillation.
So how do you prevent that?
The approach would be to wall off the pulmonary veins to isolate them electrically from the rest of the heart. The concept can be analogous to putting a moat around a prison to prevent criminals from escaping, as you can see on this illustration. But the pulmonary vein isolation, what you do is you put an electrical wall around them to prevent the atrial fib impulses from escaping into the heart.
I'm going to ask you a question that probably a lot of patients are thinking. How do you get a catheter to the heart? How does this work?
So, in other words, how do we actually do the study?
Yeah.
So, it starts after the conversation we've had with the patient discussing it. Patients come to the lab, and they're in a specialized catheter lab that we use. I mean, everyone sort of knows the concept of people squirting dye into the hearts to evaluate coronary disease. But we do electrical work, so we're the electricians of the heart, right? We put in specialized electrical catheters, but we have to get them to the heart. Patients are under general anesthesia or very heavily sedated, depending on what that particular group likes to do. They don't feel any discomfort. We access the heart by the veins in the lower part, the legs, that will let us take catheters and put them in the heart. Once we have the catheters in the heart, we start to do our thing. We look for where things are coming from, and then we try to do this isolation procedure.
Are there different ways to do this, alternative approaches?
Thank you for asking that question, Lindsay. In the first figure I showed you, you notice there was a catheter that we were isolating the veins. That was one where we use an energy source called radio frequency or heat. And that creates the line of block around the veins. But there is an alternative method, as you can see from this illustration, called cryoablation that uses a freezing method to accomplish the same goal. There have been several trials that have compared these, and they are basically equal success. And it depends on which lab is doing a procedure and up to those individuals on which they'll use to isolate the veins. Also, there are other newer techniques undergoing investigation to isolate the veins, and these will hopefully become part of our toolbox, in essence, of what we use in the lab.
So, as a patient, what questions should I be asking to ensure that I'm empowered and fully informed?
That is probably one of the most important questions you've asked, because patients have biases and doctors have biases. If somebody really loves doing ablation, It's easy to skew a conversation to ablation. If somebody is sort of an anti-ablation person and loves using drugs, they can skew the conversation. It should never be that way, right? It should be an honest discussion between the patient and their physician about risks and benefits of both techniques. So the decision to use drugs or ablation has to be discussed with your physician. Successful results using drugs or ablation doesn't mean that you'll never have any atrial fib. That would be ideal if that would happen, but it's okay also to have minimal episodes that last a short period of time, and we really call that minimizing the burden of AFib. In other words, that drugs and ablation can give you symptom-free, and that's the ideal. But many patients who are having lots of AFib can wind up having very few short episodes, and that's a good result. And that's the term that patients sometimes hear about, their atrial fibrillation burden. It goes from a very high burden to a very low burden. They feel fine, which is the really bottom line for both therapies, and it's a success. It should also be noted, Lindsay, that long-term use of anticoagulation depends on the patient's stroke risk and not on whether they use drugs or ablation as a treatment strategy.
So what happens if a person doesn't address this, if a patient is allowed to remain in AFib for years?
Lindsay, that's a really important point. It's key to understand the potential consequences of allowing a patient to stay in AFib for long periods of time. A typical scenario, Lindsay, is over time, cells that are exposed to a rapid rhythm in the top of the heart will die out. They'll be replaced with scar tissue, and then the atrium itself can often enlarge. If you look at this illustration, on the left-hand side, you can see there's paroxysmal atrial fibrillation. The atria are relatively normal in size. And then over time, as you can see on the middle part, where mostly sinus rhythm will now start to be, as the blue represents, more into persistent atrial fibrillation. And then you wind up on the right-hand side after a period of time, a scarred and enlarged left atrium. In many such patients, it becomes impossible to restore and maintain normal rhythm. It's for this reason it's important for the patient to discuss with their physician early in the course of their disease whether their normal rhythm will be important for them later on in life.
Crucial conversations. I noticed something on your graphic that I wanted to ask you about, a bridge to the future. What are you referring to there?
Yes, that's a concept I came up with a number of years ago when I was trying to explain to a patient in my office who was having minimal symptoms, but they were kind of young, they were in their 50s, which is young for me. I knew that they may need normal rhythm 20 years from now, 15 years from now, and in my discussions, I sort of came up with this term, bridge to the future. And what it really means is that while you may not 100% need to be in normal rhythm now, if you allow this to go on for years, you may get to a point where you can't get normal rhythm. So normal rhythm is a bridge to the future, a time in which maybe things change and you need normal rhythm. So if you don't have the bridge to the future, you're never going to be able to make it to the other side.
A level of protection.
A level of protection.